Good morning, and welcome to today's virtual conference on law enforcement mental health, hosted by Los Angeles County Sheriff Civilian Oversight Commission, known as COC. My name is Charmaine Mosley, and I am the new Executive Director for the Commission. Although I have been in this position for, as of today, 9 days, I have been involved with civilian oversight of law enforcement for over 2 decades through my work in Albany, New York, and San Diego. I am excited and humbled to have this opportunity to work with all stakeholders when it comes to this work. Our Oversight Commission consists of 9 county appointed volunteers from the community and 8 county administrative staff who research, analyze, and provide recommendations related to Los Angeles County Sheriff's Department's policies, practices, and procedures. First responders, including law enforcement, are trained individuals who are among the first to arrive and provide assistance or incident resolution when there is an emergency. Individuals in these positions often encounter and are faced with many challenges, issues, and conditions, which makes today's discussion extremely important. I want to thank everyone for joining us today. We have a great panel of speakers lined up. You will hear from Joe Willis, who is the Chief Learning Officer with First Help, followed by Rajiv, and please correct me if I apologize if I mispronounce your name, Ramshan, Rand's co-director, Epstein Family Veterans Policy Research Institute. Then we'll hear from Miriam Brown, the Deputy Director of Emergency Outreach and Triage Division with Los Angeles County Department of Mental Health. And lastly, Dr. Stephen Sital is the Director, Bureau Operations, Psychological Services Bureau with Los Angeles County Sheriff's Department. Your moderator for this conference will be Luis S. Garcia. Mr. Garcia is a member of our Civilian Oversight Commission, and he is also a mental health professional. And now I'll turn it over to our moderator, Commissioner Garcia. Thank you.
Good morning, everyone. Thank you, Charmaine, and thank you all for joining us today. My name is Luis S. Garcia, and I'm a member of the Civilian Oversight Commission. I also work as a senior program manager for Advocates for Human Potential, a research and consulting firm, where I work as a statewide behavioral health expert, assisting public and private mental health substance abuse providers to improve California's behavioral health system infrastructure. Also, I volunteer as an associate clinical social worker, where I specialize working with people with mild to moderate mental illness in the southeast area of Los Angeles County. As Charmaine mentioned, first responders, play a pivotal role in our communities and are in high stress positions that are often exposed to numerous crisis situations and traumatic incidents. Officers have grappled with providing public assistance to the COVID-19 pandemic and have faced increased demands to perform their jobs consistent with public expectations. Like other people in our communities, law enforcement officers may deal with work-life balance issues and may benefit by talking to someone. As we continue to evolve and learn more about mental health, suicides continue to occur. In 2020, across the United States, 116 police officers died by suicide, which was more than those that died in the line of duty. In January of 2022, the Federal Bureau of Investigation launched the Law Enforcement Suicide Data Collection to provide a mechanism for law enforcement agencies to report suicides and attempted suicides of law enforcement personnel. This should help agencies better understand and prevent suicides among current and former law enforcement officers. The Centers for Disease Control and Prevention reports, quote, first responders may be at elevated risk for suicide because of the environments in which they work, their culture and stress, both occupational and personal. This stress can be acute, associated with a specific incident, or chronic, an accumulation of day-to-day stress. Occupational stress in first responders is associated with increased risk of mental health issues, including hopelessness, anxiety, depression, post-traumatic stress, as well as suicidal behaviors such as suicidal ideation, thinking about or planning suicide, and attempts. Today, I hope to learn about the topic of law enforcement mental health from the speakers. In particular, I am curious about understanding risk factors and challenges to suicide prevention. I would also like to understand what services exist for law enforcement officers and what systemic improvements could address mental health issues among the ranks. I am very interested to hear the questions from the attendees during the question and answer session. And now turning it over to today's speakers, although we've told you the names and titles of the speakers, I invite each of you to introduce yourself, including your preferred pronouns, and a little bit about your background if you wish. Without further ado, I will turn it over to our first speaker, Joe Willis from First Help. Please go ahead, Joe.
Hey, good morning, everybody. My name is Joe Willis. I'm the Chief Learning Officer for First Help, and I go by he, him. There we go. The slides are coming up. And since I've already introduced myself, I'm a retired military police first sergeant, and I've been with First Help since the beginning in 2016. If we can go to the next slide, it'll be a video. Suicide impacts Americans at an incredible rate. It's one of the leading causes of death among all Americans each year. And all first responders are struggling with the stigma of asking for help, and they're struggling with the resources to be able to confront mental health issues.
We've been collecting data for going on 6 years now. We want to be able to track that information and say, hey, look, this is a problem that we need to address.
So we started this organization in 2016 because we wanted to raise awareness about law enforcement suicide, because we didn't feel like enough was being done for first responders or to understand the scope of the problem.
First Help's mission is in our name: honor, educate, lead, and prevent. We honor those lost to suicide and the families they've left behind, and the agencies that they've left behind, continuing to care for them and to not let their memories die and not let their death be in vain. We also educate the public, elected officials and others, on the statistics, the numbers, the challenges that first responders are facing. In the leadership space, we're directly involved in so many conversations at the national level to get policies changed, to influence public opinion.
Organization has grown tremendously over the past few years because of the love and support of the people that have lost first responders to suicide and the first responders themselves.
Prevention. At the end of the day, everyone who's lost someone to suicide knows they can't go back and undo that. And without fail, they continue to ask us to prevent the next. And we'll continue to work very hard to do that.
So everything that we do now is geared toward prevention so that we don't have to increase the number of families we support.
First Help is love. A group of people with this loss, we have a tendency to not feel loved.
And when we see these families come together and we put faces to the impact of the mental health problem in the first responder professions, it changes things.
I
Will listen.
I will listen.
Mr. Willis, you're muted.
You're on mute.
I am, and I knew I would do that. There's a little bit about our organization. I don't want to dive too much into my bio, but I'm more than happy to answer any questions about that. Throughout the video, you heard mentioned multiple times the number and the collection of data and that sort of thing. So much of the numbers that are used, the statistics that are used, come from the data we've collected, but our data is given voluntarily by individuals who know of a suicide that's occurred among first responders and report it through our website. We have a national network of folks who do this, but we rely on these submissions to have the most available data at any time. And so that number and the data associated with it is available to you at all times on our website, firsthelp.org/the-numbers. And it's pretty easy to get to from the homepage of 1sthelp.org. But what I'd like to talk to you about more this morning is some of those risk factors and one of the tools that we use to help get ahead of those risk factors. So without any further ado, let's just jump straight into the effects of stress and the risk factors. Next slide, please. Some of you may be familiar with what we call the Joyner model. It's the interpersonal psychological theory of suicidality. And what Joyner tells us is that when three things coexist in the same place, there's an increased probability of suicide. And that is a thwarted sense of belonging. I have changed my identity in some way, perhaps a divorce. I'm no longer with a unit or a team that I was once with, or I'm on admin leave, I got injured, something like that. Perceived burdensomeness, going back to that admin leave or injured or marital problems, things going on in my life where I see myself as a burden. And when we combine that with acquired capability, and what our data tells us is that the majority of police officers take their lives with their own firearm, and quite often their duty firearm, acquired capability is always present. And so when all of these things are present, there is an increased chance. Now, getting left of that, we talk about left of bang very much at First Help. And along a timeline, as we see suicide or some other major critical incident occur, quite often when we look left of that, signs existed that told us that these things were happening and that it was progressing towards this. Oftentimes, though, it's hard to identify them and react in time. And so I want to point out a couple of those things. Along this timeline, what we look for, we know the individuals in our lives, our partners, our friends, our coworkers, our subordinates, our seniors, and our spouses. And we know what the baseline looks like. And what we look for is those little things off the baseline. And one occurring, we can call it an anomaly. But when we see a series of anomalies happening together, those become a cluster. And when we see a cluster, it is time to intervene. And while I'm not going to talk about suicide intervention during this brief moment that I have, if signs of suicide are present, an individual gives any indication, it is absolutely essential that we intervene. And intervening often means asking the question, are you thinking of killing yourself? But I want to talk about way left of that. When we start seeing physical signs of weight gain or weight loss, injuries from fatigue, calling out sick more often. I can go on, and I'm sure you, and when I facilitate this with groups during training, we actually talk about it. There are a lot of physical indicators that we see associated with stress and impending crisis. Cognitive, what we see there are those simple errors in judgment, the forgetfulness, the hypervigilance, or the catastrophic thinking, the oftentimes easily bumping up against those thinking problems, the thinking traps. It's always been this way, it's always going to be this way. And we start hearing language associated with that. That's an indicator. We start seeing those errors that we haven't normally seen. Those are anomalies. When we see an anomaly start to form in clusters, that's when we intervene. Emotionally, people reacting emotionally or experiencing emotions that they're not commonly familiar with, and they act out of character for that emotion. So oftentimes we will be sitting talking to a colleague, and perhaps, and many of you have probably seen this, you're sitting across from them and you bump up against something sensitive, and you can see almost the nose start to tingle and the eyes start to water a little bit, and that's not normal for them. That's an emotional change. But we also see it on the other end of that, and the rage or the depression, those sorts of things. Many of them we're not qualified to diagnose as peers and friends and bosses and that sort of thing. But what we are qualified to see is this is not a common emotional reaction for this person in this moment. It's time for me to have a conversation with them. Behaviorally, we often see, and some of the big things we talk about are the self-medicating, whether it is through alcohol or prescription medication or illicit drugs, but we also see other things behaviorally along that path. Some of them may be extravagant purchases where they're chasing the dopamine of being in that environment to purchase something new or something along those lines. I could go on and on about this all day, but what the takeaway is on this slide is these are the four major categories of things that we will see change as an effect of stress. And when we start to see these clustering, that's where we start to worry. Next slide, please. One of the things we can do about this, though, is each of us has a range of tolerance. Dr. Siegel's window of tolerance, you're probably familiar with this. The range of tolerance, the range of resilience is what we refer to it as at First Help. And within that range of resilience, each one of us has those times where we will bump up against the upper levels, the hypoarousal, the increased state of anxiety, that sort of thing. And we have the lower end that we will be in hypoarousal, the withdrawal and the dissociation, those sorts of things. We could go on and on about that, but I'm not going to. In this middle, this flexes depending on the situations in which we find ourselves. And the goal is, through resilience training and resilience practices, is to expand that range of resilience and be aware of our triggers at the high and low ends of that window of tolerance. The way we get after that is through these 5 skills. They're very important, and what we've done is distilled a variety of programs down into these. Recognizing the good, joy and gratitude. Authentic connection, active constructive responding, relationship building, that sort of thing. Notice the world around you, mindfulness, getting up and moving, and energy management, that breathing, rest, that sort of thing. This QR code, I'd like, if you got your phone available, and we can maybe get this out to attendees afterwards, all of you can have this lesson plan at any time. Just go there. All of our full lesson plan is available to you. Next slide, please. We've also learned that one of the ways to get after this is with a focus on readiness. As leaders in this profession, we don't have the luxury of focusing only on wellness. We've got a job to do, and one of the ways to do that is through readiness. And so we look at these 4 prongs: responders, providers, supervisors, and family members. I want to tell you 3 takeaways before I close. Next slide, please. Here's what I've learned after training 3,400 first responders across the nation over the last 2 years. Number 1, suicide is the tip of the iceberg. We often look at it as the thing to prevent, but there are 1,000 ways we die or ruin our careers before suicide. And so I want to encourage everybody to think more largely and look at it in terms of readiness prior to catastrophic incidents. Number 2, train together. All first responders in the same place. Train with your firefighters, bring your dispatchers in, get them together. The conversation changes. And it changes substantially with this 3rd one when leaders are in the room and leaders talk and go first and show authenticity. Next slide, please. Ladies and gentlemen, my name is Joe Willis. I look forward to the panel conversation. Thank you so much for having me here today.
Thank you, Joe, for your presentation. Next, we'll hear from Rajiv Ramchan, who is RAND's co-director of Epstein Family Veterans Policy Research Institute. Please go ahead, Rajiv.
Thanks so much. And I want to thank everyone for inviting me here today and having this session. I really appreciate it. I also want to apologize to those of you who are in the audience or those of you behind the scenes. I sent my slides in late and I joined the webinar with 3 minutes to spare. So I apologize for being a little bit delayed, and please accept my apologies for that. And I'm grateful for your willingness to still listen to me. So I really thought that, and thanks, Joe, for setting the stage. What I thought that I would do is really present a highlight of research that I did a few years back. I don't think much has changed since then. Rather than tell you about the risk factors for suicide and things of that nature, I want to give you a sense of what law enforcement agencies across the United States are currently doing for preventing military suicide, so that you can identify, what are other organizations currently doing, what might hold promise, and you can also think about where your organization or institution might fit in the scope of things. As a little bit of background about me, as was mentioned, I co-direct a Veterans Policy Research Institute on RAND, but I've been studying mental health and suicide since 2008. The majority of my work is in the majority of my work has been in military and veteran populations, but I have done a lot in law enforcement, including both federal law enforcement agencies, as well as this study that I'm going to present to you too. So I also, anything I don't get to, I look forward to the panel discussion. So the next slide, please. So the first thing is that it's important to recognize that there's thousands of law enforcement organizations in the United States. 50%, over half of law enforcement agencies have 10 or fewer officers, but the majority of police officers or law enforcement is in a force with 100 or more officers. And this gives you kind of a breakdown of what we're currently looking at when we look about law enforcement in the United States. So that variability or variety says that there's probably not going to be a one size fits all strategy. And we're really going to need to adapt it based on kind of the size and the resources that the agency has available to itself. Next slide, please. So as I mentioned at the introduction, we wanted to understand better what was happening in the space of law enforcement suicide. So what policies and practices are U.S. law enforcement doing to prevent suicide? What services are organizations like the one Joe just spoke of offering to prevent law enforcement suicide? What nonprofits are kind of augmenting? I'm not going to present those results today. And then what are the policy, sorry, the second one should actually say international law enforcement agencies, but I'm not going to present those results today for time. So US policies, programs, nonprofit organizations, and international. But if you want information on those, I can send them to you later in a larger slide deck. Next slide, please. So the way that we did this was conducted 5 rounds of surveys with agency representatives across the United States. We first were very broad. In round 2, we kind of remained broad, but then we started to get really specific. So in round 3, we really wanted to identify rural agencies. In round 4, we wanted to identify the state agencies, so state police departments and, that had the largest suicide rates that we hadn't already interviewed. And then this might be interesting to you all. In round 5, we restricted it to sheriff's departments with the largest jail populations. So because we had heard a lot that sheriff's departments, especially those who had responsibility of overseeing jails, were some of the most stressful jobs that law enforcement agents were assuming, I guess. Next slide. Let's get to the results. But before I get to the results, this is basically, what we ended up. 110 interviews with agencies across the U.S. representing 30 states, and we had, some decent rural composition. The reason that rurality is important is because rural states and rural regions of the United States have higher suicide rates than urban areas. Next slide. So we categorized agencies with respect to 4 different types with respect to the mental health and suicide prevention services they offer. The first are those that offer minimal services. And basically here, mental health is available through an EAP that's available to all municipal employees. So there's really not doing anything. And these are some example quotes of things that we heard. There aren't any formal policies because it doesn't seem to be that big of an issue. We're all friends. We go out after work, go to each other's houses. We talk off duty. It's a small town. We all know each other. We don't need anything special. Until something really bad, this was the most common though, until something really bad happens, it's not on the forefront of our minds. We had 5 inline deaths. So during that period, everyone was really hot on addressing mental health as an issue. But once things quiet down, it's easy to get pushed to the back burner. So we heard that kind of repeatedly, that it's a very reactive issue. There's a lot of suicide within an agency or within a region. And all of a sudden it's elevated to the top priority. And then there aren't a few suicides for years and other things start to compete with the resources that have been invested. So we see programs either dismantled, shut down, or lose kind of the excitement and they kind of dwindle down. So there's no sustained period. And that was pretty common. Next slide. The second kind of category, and this was a lot of agencies, 37 of the 110 we spoke to, we would call basic services. So mental health is provided through an EAP or a contracted community provider. A lot of times these EAPs or community providers are on a list, or they claim that they have, they can, specially work with law enforcement, that they have some training and cultural competence and cultural humility to deal with law enforcement suicide. I will say though, with respect to that, that's a really interesting question. And there's diversity within those who kind of specialize in working with law enforcement agencies. One of the areas that I find most interesting, and hopefully we can talk about in the way that they specialize, is if you ask them, do you let your agents bring their firearms into them for a counseling session? And it's a pretty mixed bag out there. Some of them say, yeah, their firearms are identity. I want them to feel as close to themselves as they are. And so I'm not going to restrict what they can bring in. And others really try to dismantle that identity. No, I actually want them to create an identity that's not dependent on having a firearm on their right hip. So there's a lot of discussion about that, about kind of that variability and what that cultural competency means, that I think is really interesting. Other things that that law enforcement agencies with basic services offer are things like volunteer chaplains. Many of them have what we would call critical traumatic or incident stress management programs. Here we have smaller agencies that rely or contract on outside teams. Larger agency rely on trained peers. This is when a critical incident occurs that law enforcement are exposed to, having some kind of mandatory session afterwards. What's interesting, the question is, what constitutes a critical incident? We did hear things like mass shootings, which seems relevant given yesterday's news, but also we often heard a lot about child fatalities in highway or automobile accidents as being critical incidents that typically precipitate this type of stress management program. And then training. So some of the trainings that Joe just mentioned, in-service trainings on stress reduction, or trainings at the police academy on stress reduction, or even trainings on the resources that might be available in the community. But again, this all falls under the basic services category. Next slide. The next is proactive services. So here we have a few more. These may be larger agencies. I'm going to talk more about in-house mental health care, but sometimes you embed mental health care providers or chaplains within the unit. So they hire staff who are embedded within there to kind of walk around and take a pulse on how individuals are doing within the agency. They often have programs to address substance misuse. So for example, we had they had agencies that ran their own Alcoholics Anonymous meetings for members of law enforcement within the agency, because there was a lot of concern that Joe raised again about stigma in the community for a law enforcement officer to go to an AA meeting, perhaps in a local church or something where people might know them, that they're members of law enforcement. So this was a closed AA meeting. Often they have peer support programs, which I'll talk about. They have programs that screen, so that can take many different faces, shapes, and forms. And then they'll often have an official health and wellness program that includes not only stress management, maybe some yoga classes, breathing techniques, eating healthy, exercising, things of that nature. Next slide. So thank you. The in-house mental health care was really what we saw in larger agencies with 1,000 or more officers. Often it was short-term counseling. So, you've heard things like 3 sessions per presenting issue or something of the sort, but some also offered therapy. So for example, evidence-based therapy for something like PTSD would require, anywhere up to from 8 to 12 sessions. And some in-house agencies were offering 12 sessions to go through a full course of prolonged exposure or cognitive processing therapy. The providers often assume other responsibilities. So they're not just providing counseling for the law enforcement officers, but they're involved in hostage negotiation. They help with training. They do a lot of return to duty investigations. That's also a really interesting kind of responsibility. So in some agencies, we saw this split, that some mental health professionals working for the agency did only return to duty investigations, and some provided that counseling or therapeutic services because there was worried about conflict of interest, perhaps. Somebody who's doing return to duty investigations who's also been counseling somebody for the past 12 sessions may be biased in kind of how they are assessing the individual's risk or readiness to return to duty. In both ways, the bias could happen in either they could be perhaps more lenient or more strict in their criteria. The peer support programs also really varied. Oftentimes, law enforcement officers were vetted, selected, or trained to assume these positions. The ratios, sometimes we saw there was 1 peer trained in this role to every 10 officers. Sometimes it was 1 to every 50. And we've seen a lot of kind of different versions of this type of thing. Next slide. This is the last, sorry. Sorry. These agencies don't often offer all of these things together. The majority of them have just 2 of those things that I just highlighted. Some of them have 3, but it's not like they're doing all of them. they're doing like one or two of those things, or perhaps three of those things. Next slide. So finally, we saw a few agencies that we think are provided integrated services. And I really want this here. You have suicide prevention and mental health services integrated or baked into day-to-day operations. I think this is really important because the thing that's always struck me about the literature about police stress is that so many of our programs are focused on, those fatalities and automobiles or critical incidents. But when you ask law enforcement officers about what's stressful about their job, those things are traumatic, and I don't want to diminish the trauma and the stress that they endure. But a lot of times you go into police work expecting some of that stress. You're expecting to go to those, not everyone, and not everyone can handle it, but there is some expectation. What they don't expect often is the administrative oversight, the bureaucracy, the scheduling problems. Like, we hear a lot of young officers tell us about, what's stressful for them is that they have to work every holiday and overnights. And often these are the officers with young kids at home and spouses who are working. And so just scheduling is a stressful kind of situation for them. The schedules that they kind of have to do, and that they're not prepared for those types of things. So when you think about it, integrated services, we're thinking about policies that are addressing things like harassment, abuse, scheduling difficulties, hierarchical scheduling, we call it. Some of them have policies for restorative sleep. So they'll recognize when people are working too long or doing overnight shifts, and then have policies that they can come in and take essentially naps, but really it's restorative sleep to make sure that they're sleeping well. And then they also have health and wellness units within the departments that oversee everything. So it's not collateral duty. There's an agency that's doing this in a strategic way. Often they have additional duties that, to notify family members. So it's similar to a CAO in the military, for those familiar. And then mental health units that dually function for officers and families. So they often offer services not just for the agency or for the law enforcement agent, but also for their family. And I think I have one more slide. Sorry for going long. So, what we concluded really with respect to, and what I'd leave you with, is that a lot of efforts are focused on building awareness. There was no agency we spoke to that needed to be convinced that stress, mental health, or suicide was an issue that needed to be addressed. Everyone's like, yes, it's top of mind. We're always thinking about it, except for those times when it kind of falls behind the wayside because other things compete. But we don't need to do much more awareness in kind of elevating the concern. What we really need to do is offer kind of supports. We think from a research perspective, we really need to go under the hood. So it's great to know that you have a peer program, but is it working? It's great to know that you're screening for suicide risk, but what tools are you using? Are they evidence-based? And are you picking up? Screening is a really kind of complicated issue, because if we're screening for something super rare. But if you're screening for something and then telling somebody that they meet criteria for depression or suicide risk, well, what's next? It's screening, and it has to be followed with somebody. Just telling someone that they meet this criteria and not making services available for them immediately is almost a disservice, right? You don't want to be told that you have cancer, but you can't get treatment for another 8 months, right? You want to be told you have cancer and we're going to start you on treatment tomorrow, or your next appointment is tomorrow. Same with mental health screening as well. There's a lot of controversy about critical incident response, about whether people should be forced in group settings to reveal kind of how they process incidents, and whether it's effective. Sometimes it cannot be effective. So really thinking about quality. And I know that LA Sheriff is a really large agency, but these smaller agencies, I think we really need to be, and if anyone in Facebook Live is part of a smaller agency, thinking about how smaller agencies should be doing this, because they might not have the resources. But we've seen really creative things where, for example, programs were shared between, as Joe was mentioning, between police, fire, EMT, so kind of co-services for everyone, but also programs, different small agencies within a larger area would kind of combine forces and do joint trainings and joint sessions. I think that's all of my slides. Sorry for running over. I hope that was helpful. I look forward to the panel discussion, and please email me if you want any of the documents, the papers about these topics. Thanks.
Thank you, Reggie. And now we'll hear from Department of Mental Health Deputy Director Miriam Brown. Please take it away, Miriam.
Good morning, everyone, and it's a pleasure to be here with you all and all the information that you gave. My name is Miriam Brown, Deputy Director for Mental Health, but most importantly, I am a clinician and have experience and have the privilege to work with a lot of law enforcement, Sheriff's Department, LAPD, and the other smaller agencies, and really see firsthand the tremendous amount of stress that they go through. And really, from the clinical perspective, I learned that as a clinician, we'll go there and we have the opportunity to really kind of talk to the families, spend a lot of time with the families, and really gather more information. Unlike, law enforcement, the expectation is handle the situation, take care of business, and go on to the next call without having that opportunity, to really just take some time to go through the process. So I have all the respect to law enforcement, and unlike my prior colleagues, I'm not going to go into any type of statistics or really suicide. I want to begin with mental health and wellness. And what does that mean? Next slide. Mental health really includes our emotional, psychological, and social, physiological, and social well-being. And what that really means to me, from early in my career, I always felt that, we always pay attention to our physical health. I have a headache, I have stomach ache, I have this, that, or the other, and we kind of handle that immediately rather than make it really make the problem worse. Unfortunately, mental health throughout the years was not accepted, as part of our, well-being, as part of our own lives. I think that one of the components that I'm grateful for COVID is that mental health really came to the forefront. And why wait to mental health until it's a suicide and just be reactive about what we need to do? Mental health is important across our lifespan as children, as teenagers, adults, older adults. And it really kind of, if we pay attention to that from the very beginning of our lives, we're going to be more successful on how to manage both. Next slide. Having a good mental health or being mentally healthy is not just that, oh, we're not mentally ill. We all have our own mental health. We all have our own, personal struggles and our own life. As my colleagues before talk about, the stress that we have on our day-to-day activities, our children, our scheduling, our family, our parents, many things that we have to manage. And then we have to kind of work with, our stress on our work. Oftentimes it's very overwhelming, but rather than really, pay attention to that, we just keep going and moving on to the next task that we need to do. And really, what is the concept of mental health, good mental health? It's the enjoyment of life. And that's where we really, with our law enforcement, with in any career in generally, is how do we balance work and life, our own life, and how do we enjoy life? It's not an easy task because oftentimes we get so involved on our day-to-day activities of work, and then we go home and we just do what we have to do without paying attention to our own self. So, and then when we have a good mental health, then it provides us the ability to bounce back and really deal with stress and sadness and all the other stresses of life in a more natural way, in a better way, because we're allowing ourselves to really feel the emotions and go through the process. Next slide. And it's very simple, it's very basic, what we all do, but oftentimes, I include myself, I forget about that, and I had to have reminders, of our healthy life changes that we have to make. We need to pay attention to ourselves in order to be well for our families, for our coworkers when we are there, law enforcement when they are there in the community, providing, from CPR to, giving death notifications, trying to work with a child in a car accident, and just trying to get that, we forget about ourselves, and we forget about just the basic things that we can do. Exercise daily, 30 minutes. I know it sounds very little, but we are so busy in our day-to-day lives. 30 minutes of our life, we say, okay, God, how can I get there when I'm so tired? But I had to tell you from my own experience, it really makes a difference. You are tired, but after you do that 30 minutes of exercise, you feel much better. One of the recommendations I have made to a lot of people, because it really made me get into that discipline, get a trainer. And you don't have to have a trainer for life. If you have a trainer, for about 3 months, you learn, some of the things that you have to do, because it's not really just about being in good shape, but also being in good mental health. Avoid alcohol. Sometimes it's easy to have a glass of wine, or a beer, whatever the choice is. But taking alcohol, it's a lot easier than going to the gym. I get that, because you get home, you can have it, and that's the end. Or some people prefer to eat sugar, or drink the drinks that we have that have high sugar levels, in order to keep us awake, in order to just keep going, and not paying attention to what's going on with our body, with our mental health. Learn new things, learn a new recipe to eat healthy. You really just, again, it's not a lot, it's very simple, but I just wanted to begin with things that we can do to begin to take care of our mental health, rather than just wait until our mental health, it's not in a good condition, or it's getting to the point that we're really depressed, we can't make it to work, we don't like work, we get upset easily at work, and we're not paying attention to what's going on, including when we are driving. In today's society, because of technology, we are more busier than before, because we're a phone call away, we're a video call away, we're in a conference, and more often than not, it's a constant information that it's going to our brain, to our system, whether it's through the radio with law enforcement, the radio, the constant radio that it's going on, you're constantly busy. Those are things that, doesn't provide a good mental health for us. Next slide. What else can we do besides physical activities? I think that right now we are in a country, just like again Michael has mentioned about suicide and the high rates of suicide, and it's really across the board. It's with children, with teenagers, with law enforcement, because of the pressures that we have. One of the impacts that I have seen with COVID is that we're short-staffed. We have challenges hiring staff. Therefore, we are busier than before. We are paying, we are working more overtime, longer hours. So let's try to do something, to feel better. Volunteering, do something that you like, drawing, singing, painting. Enjoying times with friends and family, but I'm talking about quality time, not texting or a phone call. Go for a cup of coffee, go for a walk, eat good, and complete personal goals. Have personal goals for yourself. Next slide. Limit, what impacts our mental health is the use of alcohol. There's an increase in domestic violence, bullying, or abuse from others, significant trauma, like if we have been in the military and now we're law enforcement, that really increases, the impact on our mental health. Next. How does mental health affect our well-being? Having good mental health makes our life easier. It helps us to feel calm ourselves when we're upset. So that's why exercise, eating good, taking priorities for us as an individual is really important. It allows us to cope with losses. In law enforcement, there's constant losses, because that's what you all see when you are in car accidents, all the traumas, officer-involved shootings, all the negative that it's, oftentimes projected out there by the media. Develop good relationships. If we have good mental health with physical health, we are going to develop good relationships. We're going to be able to help others. And having good mental health doesn't mean we have to feel good all the time. There are times that we're going to feel sad, that we're going to feel, the loss. We are in the holiday season. This is a season where oftentimes we remember our loved ones that we lost for whatever reason. It's sad. Sometimes, the days are shorter, it gets dark, really early. That kind of brings a little bit of depressive mood to some of us. And it is okay to feel sad. It is okay to feel depressed. Rather than ignore, just go through the process. Next. And here's like a summary that I did, 30 minutes a day, it really boosts your mood if you exercise. Eat healthy, drink water, make sleep your priority. Turn off your, I know we're connected, but text messaging, turn them off. Unless you don't call, and if it's an emergency, then, have it on. But I personally, that I'm called most of the time, 24/7. There's a time during the week that I am not, and I turn everything off to have a good sleep. And I tell my friends, my family, and everybody, this is my day. I need to take my time. Try relaxing activities, even during the day. Take 5-10 minutes just to take a walk, just to talk with a friend, with your coworker. Be kind. Practice gratitude. There's two things that sometimes help so much. Good morning, good afternoon. How are you doing today? Just stop and think about it. I know that sometimes as an administrator, I'm so busy that I'm going for the next thing to the next thing to the next meeting to the next conference. But I had to remind myself, I had to stop and say hello to people out there. I have to socialize with people and see how are they doing. And don't pay attention to the social one, the one that's always laughing and socializing, and you know that. Pay attention to the one that is in the corner, isolated, the one that just does their job, does their paperwork. Just check in with them and stay connected. It's really critical to stay connected and to really not just with law enforcement, but your family, your friends. I know sometimes we say, I don't really have time, what, but I'm gonna call my friend tomorrow, and that tomorrow never arrives. So it's next slide. 5 steps to mental well-being. Learn new skills, give to others, pay attention to the present, stay in the moment, the mindfulness. Be grateful for what you have and really take care of yourself. In closing, my recommendation is to all the law enforcement partners that I respect for the work they do, and how much they save lives out there, be in public safety, be under a tremendous amount of stresses. Take care of yourself. Be mindful. If you're not feeling well, pay attention to that. What's going on? Talk to your friend, to a coworker. I know a lot of people don't like to talk EAP. County employees, you mentioned EAP is the first thing they said, I'm not going to talk to them because they're going to tell my boss. Well, now we have our new hotline, the mental health hotline. We have that 988, which is the national mental health line. It's private, it's confidential. You can text, you can talk. You don't have to provide your name, and they can talk to you at any hour. There's 24/7, so you don't have to give your name. We also have our access helpline, the 1-800-854-7771, similar to the 9-800, but that's a Department of Mental Health. When you can just make a phone call, you don't have to provide your name. You just request to talk to a counselor or professional. If you don't want to use the term mental health, that's fine. But it is really important to pay attention to those things. So be mindful, volunteer, but most important, take care of yourself and pay attention not only to your physical, components, to the physical problems that you may be experiencing, but to your mental health. If you are too worried, too preoccupied, too busy to take care of yourself and to take time for yourself, think about it and give yourself a gift. Be kind to yourself. Thank you.
Thank you, Miriam, for your excellent presentation. Now we'll hear from Los Angeles County Sheriff's Department Psychological Service Bureau Operations Director, Dr. Steven Setal. Please take it away, Dr. Setal.
Maybe a mute.
I'm sorry, are you on mute?
Okay, can you hear me now?
Yes, thank you.
Okay, sorry about that. So I was rambling on a little bit. I'm not sure where I got cut off there. But what I was saying was I've been with the department for roughly about 13 years, and I've had the privilege in that time to do quite a bit with the department. Part of what I've been able to do is participate and contribute to some large training agendas as it relates to our department's crisis intervention training programs. I've also worked as a law enforcement psychologist for our department, where I've been able to provide free confidential counseling for our department members and their families. And I've worked as a industrial organizational consultant for our department internally, where I was assigned to our Central Patrol Division for about 6 years, providing a variety of psychological support and consultation within that division, to the stations within that division. And so it's really been a privilege for me to serve the department. I've had an opportunity to do quite a bit. And in the time that I've worked for the department, really having an opportunity to get a better understanding of some of the things that our panelists have talked about this morning in terms of pressure and stress, and certainly appreciate the perspective related to self-care. Next slide, please. So just a little bit about the history of law enforcement psychology as a specialty. It really evolved here in Los Angeles, starting with LAPD. And I'll also acknowledge my counterpart, Dr. Edric Dorian, who is the chief psychologist of the Los Angeles Police Department. They have a behavioral science services unit that provides many of the same internal functions that Psychological Services Bureau provides for the Sheriff's Department. In terms of our department, we have employed psychologists internally since the mid-70s. The focus has always been on being able to use behavioral science and the practice of psychology to both enhance the organization as well as the health and well-being of our employees. So since the mid-70s, from the time that our department first started employing psychologists, this was really the primary focus, was really a wellness-related or well-being related mission for the employees and the organization. We continue to work on providing organizational recommendations for the department. And then probably certainly right now, and in my view, one of the most important things we do is continue to provide emergency 24 hours a day, 7 days a week, round the clock support for our employees and their family members that may be in crisis. And certainly that's something that, especially during this last year, has been very important for our department. Next slide, please. just a little bit about our size, just so you get a sense. So our department is about 16,000 employees, give or take. Our budgeted positions within our bureau consists of 1 director, 2 assistant directors, all licensed psychologists, and then 20 psychologists that provide either a law enforcement psychology function, which I'll talk a little bit about, or more of an industrial organizational consultant function, which I'll also speak about. And there's some overlap there between what our professionals do here in the bureau and for the department, but we are budgeted for about 20 psychologist positions in addition to the licensed psychologist managers. As part of our bureau, we also have 2 2 sworn deputies. One runs our substance abuse resource program, which we'll talk a little bit about, provides access to those resources. The other one is our coordinator for peer support and is primarily responsible for outreach and engagement to facilitate the connection for new peer support members to come into the program, as well as providing education on what peer support does and coordinating ongoing training for our peer support cadre. And currently we have about 160 active peer supporters of all ranks and classifications within the department. As part of our team, we also have a number of positions, 8 current positions that are more administrative in nature. And so the professionals that work in those positions really provide a lot of support for all of the facets of our operations. Next slide, please. So let's talk a little bit, we'll do a little bit of a focus on some of the programs and the services. So as it relates to our counseling and intervention, first of all, I'll say that our bureau has between 5,000 and 6,000 clinical contacts or counseling sessions that we do annually. So just to give you a sense, again, we're offering free confidential counseling for department members and their families. And we average between 5,000 and 6,000 clinical contacts, either an outreach contact, which I'll talk a little bit about, or debriefing or counseling appointments for department members and their families. Outreaches are to employees. They're made by request, employees that might be going through a work-related crisis, a personal crisis, or a medical crisis. Our psychologists will make an attempt to contact them privately and speak with them and make sure that they have the support that they need, whether that's internally within our bureau or if they have a strong support system. We will also connect them to the appropriate resources if that support system is lacking in some way and if there's an additional need that's identified. As it relates to the clinical services, I mentioned the counseling. We do also provide, in addition to services for department members, we do provide services for their families. We do couples therapy, and we'll talk a little bit about why folks come in, but it is a huge part of what we do, and we are decentralized so that we have smaller satellite offices as part of our operation throughout the county. I'll also say that part of our clinical services involves a cadre of culturally competent in the manner of understanding the law enforcement profession, mental health professionals that provide counseling to our department members. And so if for some reason somebody can't be seen within our bureau here, they are provided the resource to see somebody externally that's also connected with our bureau. The emergency response that we do is related to critical incidents, any type of a mass casualty, situation where our department members may be deployed to provide service, or our department members are injured in the line of duty, we will deploy. And we are fortunate that we have a cadre of chaplains, which I'll reference, and our peer supporters, which I've referenced. So typically when we're engaging in response to larger incidents, it is a co-response where we'll have peer supporters it's not unusual to have chaplains as well as our psychologists role and spend time providing for the needs of the employees or their family members that are affected. We do provide a number of customized trainings, both per unit as well as at the department request. Examples of those we'll go into in a few minutes, and then specialized projects. So we do, for example, we are currently working on awareness campaigns as it relates to substance use, alcohol, and pain medication, and then, of course, the crisis related to mental health as well. Our peer support, our cadre of peer supporters, we have our general peer supporters. We also have peer supporters that are specific and focused on our veterans that are part of our department. And then we also have a DIS team that responds following a critical incident involving a shooting, and they'll respond and provide support in those facets. Next slide, please. We do have a cadre of chaplains that provide spiritual guidance and support for department members. Many of these chaplains are assigned to a specific unit where they have the opportunity to build rapport and to get to know the personnel within the unit. They also, as I mentioned, are engaged in our emergency response. So if there's either a request for a chaplain based on the circumstances of a crisis, or if we feel that it would be a benefit, we will also include a chaplain as part of those responses. And so certainly they're part of our first line of response, and we are grateful to have the amazing cadre of volunteer chaplains that we do for the department. The Substance Abuse and Resource Program provides education and linkage to services that are specific to law enforcement. Those might be anything from an Alcoholics Anonymous based program specific for law enforcement to outpatient treatment, to some of our specialized inpatient treatment providers that we have relationships with. And so the deputy who runs that program provides access to those resources and also goes around to various units throughout the department and provides awareness education and support regarding some of the signs and symptoms of an individual that may be in need of some of those additional supports. Next slide, please. So in terms of our counseling operation, we talked a little bit about the emergency on-call service. We do have a full outpatient facility that is really, it functions as a large private practice, except that it's internal. We don't have stringent time commitments. We do try to, just because we are limited in terms of the professionals we have, we do try to provide shorter term or briefer therapy. That may vary for individuals depending on what their presenting circumstances are. Our psychologists are also trained in evidence-based treatments such as EMDR and some of the specialized treatments available for couples, EFT. So we do work on continuing to develop some of the competencies that coincide with the presenting issues that folks are coming in for. We have 4 office locations right now. We are available between Monday through Friday during business hours, but then we have the emergency on-call resource where our psychologists and also peer support are available after hours. The connection to externalized service providers ranges. So we have connections with a lot of agencies that provide specialized services externally regarding substance use, regarding trauma exposure. As you see, we have a smaller group of internal providers. And so as a bureau, we are well aware that we are in need of our providers externally that are able to offer quality service to our department members. And so we really work on developing those relationships so that we can streamline referral when it's appropriate. And certainly look for those opportunities to develop additional relationships with providers that can offer our department members quality service. Next slide, please. So these are some of the main reasons why individuals will come and see us. And I don't think that there's, for our panel and certainly for folks that work in the profession, I don't think there's anything surprising here. The number one issue that our department members will come and seek out services through our bureau for really relationships. But there are a number of circumstances that will bring them in. And so we really work on developing a sense of safety. We do have the benefit of being within the department for a number of decades, and so the trust is there. We don't have any of the conflict of interest that perhaps some smaller agencies might have to negotiate because of having to juggle multiple roles. We do have the benefit of being here strictly for our department members. We don't do any type of fitness for duty or return to work, structured return to work as part of our services. Next slide, please. These are just examples of some of the trainings and some of the consultation that we provide. So with our IOs, our industrial organizational consultants, they are really serving in an embedded model where they spend about 80% of their time on duty in the field, embedded within a unit. The goal is to cultivate a sense of trust so that they can provide services within that environment. And those services may be everything from just simple psychoeducation related to mental health and wellness, to consultation with line supervisors or with unit management regarding recommendations to streamline some policy or procedure so that it may run smoother. But they're always looking out for the well-being of personnel in those units. And so it's not uncommon for them to go and just spend time and talk with folks. And really, they are our first line in terms of being able to recognize and identify individuals that might be in need of a higher level of support and flow them back into our bureau or to an appropriate resource. And then we have been able to develop and work with our other partners within the department on developing policy. We have policy related to critical incident debriefing, related to alcohol and domestic violence related incidents, and then also our peer support and confidentiality protections around peer support contacts. And we've had the privilege of being able to collaborate and contribute in those respects. Next slide, please. That's all. Thank you.
I'd like to thank all the speakers here today, this morning, for providing the information related to law enforcement and mental health. Our conversations here today are important, and we hope that this information continues to be shared to reach those who may benefit from it. Before we jump into questions from the public, I'd like to ask the panelists a few questions. And my first question, I'll direct it towards Dr. Seetal. So recently, news reports, there was, a few weeks back, 3 active duty personnel, a sheriff's commander, a deputy sheriff, and then a custody assistant and a retired former department member that died by suspected suicides in a 24-hour span, which was pretty alarming. You shared about the services that triggered, what triggers an referral or self-elected visit to the outpatient service or location that you mentioned. And can you kind of expand on the outpatient services a little bit more? And what kind of if suicide prevention efforts are also included within that?
Yes, absolutely. So when department members or their family members come into our bureau for services, if they're seeking services, part of that process is an initial assessment of their current circumstances, what their presenting issues are, and then including risk factors as well. So right from the beginning, in terms of the outpatient services, we're looking at their level of risk. We do use measures to assess risk internally within those contacts, and then we make appropriate recommendations for treatment. But risk is something that we look at immediately. As it relates to risk too, I'll also provide that I referenced outreach contacts that we make. When we're making calls to individuals, we are certainly assessing where they are and what they may need, but we're also assessing if they're in a place of crisis. And so part of that is being able to assess what support we can provide them, but also assessing where they are in terms of a level of crisis. And there are times where we contact people that are going through a medical issue, or perhaps a family issue or grief-related issue, or perhaps they're injured off duty for some type of situation, and they're in need of support, a higher level of support, and they might be in an acute state of crisis. And so we will provide the services and the support necessary to get them help.
Thank you. And I have another question directed towards the organization and operations psychologists that you were sharing within the custody division. You mentioned the DVRT and CIT trainings for custody, and over the course of the year, there's been a significant number of inmate deaths, and exposure to a death in custody by whether it's the healthcare staff and custody staff. I would think it has an impact on a professional in that setting. And I was just curious if there is any kind of like a debriefs or any services, or I guess it would be what's the word I'm thinking is like outside of a referral to going to somebody seeking some outpatient services, but within these within the organizational development or organizational psychologist side, is there any kind of trainings that look at that, like trauma trainings for the staff or what they observe and witness?
Yeah, so as part of the de-escalation verbal resolution training, there is a day that is focused on wellness, employee wellness, and being able to take care of oneself. So self-care. That's both part of the divert program as well as our CIT program for our field-based personnel as well. And so both of those programs are taught collaboratively between psychologists as well as sworn partners. And I think just in terms of a matter of best practice, really, if you look nationally at some of the training programs that are provided, best practice is really that you have a mental health professional, regardless of their level of cultural competence within an organization or within the profession, that you have a mental health professional, and that you also have somebody from the profession, somebody sworn or somebody that has been on the line or been part of the scope of practice that law enforcement professionals are engaged in, to provide that training so that you have really a balanced perspective. And we have that certainly with those programs.
Thank you. Okay, so Miriam, my question, thank you so much for providing those mental health and wellness and well-being areas of awareness for the public and for this presentation today. In the spirit of collaboration amongst different various county departments, I was just curious, like, is there any type of collaboration with DMH and the Sheriff's Department, like, to promote some of these wellness efforts that the Department of Mental Health is putting out there? To, like, I know across like various other departments, there's information that's shared from DMH. So I was just curious if that's kind of what you presented, is that like available for the Sheriff's Department or their families?
Yeah, most definitely, it's available. It's for the families, for them, and we do work very collaborative with the Sheriff's Department. We have a collaborative with our mental evaluation team, where there's an officer and a clinician. So there's a lot of collaboration with that. I also work very closely with the homicide division when it comes to officer-involved shootings and the inmate, and I'll be more than happy to provide that information and whatever else you may need.
Thank you. And my next question will be for Joe. Thank you so much for your presentation, and from the peer perspective, can you elaborate on any efforts that have been made to overcome the challenges to suicide prevention among law enforcement?
Yeah. So holistically across the nation, there are a variety of organizations similar to ours. In fact, I'm here today at a first responder conference in Salt Lake City, near Salt Lake City, Layton, Utah, but they've done them throughout California as well. One of the things that I think we need to kind of narrow the question just a little bit if we can, because as my other colleagues here kind of alluded to, it's so much bigger than just looking at suicide prevention as the one thing. And my heart goes out to the sheriff's office, having experienced a suicide within the ranks. I know everyone there is hurting, and everyone there is affected by it in some way, especially the leaders and peers across the organization. So when we look at suicide as the thing to prevent, I think we need to start looking left of that much more. And everyone on here talked about it to a great extent. So where we see the biggest impacts are when we have the triad. I think somebody else kind of mentioned it here as well, but you've got well-trained, culturally competent, and experienced chaplains for the spiritual component. You have culturally competent providers, whether they are embedded or for smaller agencies within the community, and you have peer support that is trusted and well-trained. When you have that triad of resources, I think we see the biggest impact. We could go on and on about organizations similar to ours that are providing resources, but I think organic and close to the ground in the organizations where we see the biggest impact.
Thank you for that. And also one thing just to add, you brought up the window of tolerance and how individuals can be elevated, or if they can be kind of lowered, maybe something's observable. I think there's more training on that, recognizing some of the indicators, and also just recognizing the awareness of being in that window of tolerance space is important for your overall well-being, and to think and feel at the same time will assist. Such an important topic. My next question is for Rajiv, and I appreciated your research and the larger kind of systemic overview. What systemic changes do you think can be made by law enforcement agencies to address mental wellness among the ranks and across systems?
I think agencies need to do needs assessments of the unique stressors and groups that are particularly stressed. When I think of law enforcement, or when I think of a workplace, let's just be more broad. What does a workplace have control over among its, they have some control over their insurance, right? They have control over, but thinking about like what stressors they have control over and how they can attempt to minimize those stressors. So we did research for one organization, and we saw a law enforcement agency, and we saw really high rates of peer-to-peer harassment within that agency. And those people who reported being harassed by other law enforcement officers had reported more stress. So suicide prevention could be a zero tolerance policy for harassment or something of the sort, addressing harassment. And I think that speaks to, what Joe's talking about, getting left of boom. Like those are the types of policies. So I always think a needs assessment is a really helpful place to start to identify the populations that are stressed at work and the causes of that stress. You know, another stressor, and again, this is a larger one that I don't know about, is that we heard about was cost of living stressors in certain agencies. So essentially, law enforcement officers who were not sleeping very well, who were resorting to alcohol. But it's not that they didn't have time, and I appreciate, you know, Miriam's talk about, you know, finding time to eat, finding time to exercise. It was that their commutes to work were so long because the cost of living where they were assigned was so high. So there were really kind of physical barriers. I don't know how law enforcement agencies are addressing issues like that, but we should be cognizant that those are things, those are real things that are stressing out our law enforcement officers. And so, you know, I think, you know, resilience program or mental health to help the person who's been victimized by harassment is always going to be helpful, but it's always kind of a little bit too late. We should be addressing the harassment that's happening. Or, you know, if something's happening, but the person's still tired because they're driving, we have to get at some of those root causes if we really want to make systemic change. So I would think about that needs assessment and identifying what are the types of stressors and taking a really broad, you know, approach to that. Don't give them items and ask and tell them to endorse them in a survey, but really talk to these individuals in a systemic way and your workforce and say, you know, just have them bring up what are the things that are stressing them out.
Thank you. And thank you everyone for your excellent presentations today. And now we'd like to open it up to the live Q&A portion. Nunya, are there any community questions for the panel?
As a reminder, if you logged into WebEx to ask a question, please raise your hand. If you have called in, please press *3 to get in queue to be unmuted. I will unmute you when it's your turn so you can ask your question. If your question is for a specific panelist, please feel free to state that. To ask a question, you must be logged into WebEx or phoned into the meeting. We will not time the Q&A session. This session is only for questions and not for comments. And before we begin, we will have a quick announcement in Spanish. Daniel?
Hola, buenos días. Ya ha iniciado la conferencia por WebEx y le gustaría hacer un comentario o pregunta sobre el tema. Por favor, oprima la imagen de la mano y alguien le ayudará. Si está escuchando la conferencia por teléfono y le gustaría hacer un comentario o pregunta, por favor, oprima la tecla de la estrella y el número 3 y alguien le ayudará cuando sea su turno. Si está viendo la conferencia en vivo por Facebook y ha escrito un comentario o pregunta, la coordinadora de la conferencia la va a leer al grupo. Por fin, si su pregunta es para una panelista específico, por favor indique eso en el comienzo de su pregunta. Muchas gracias.
And Commissioner Garcia, I don't see anyone asking a question. But a question came through chat, and let me read it. The question is from Sandra Kramer, and it's addressed to Joe Willis. You mentioned that you recommend various types of first responders training together because it allows for deeper levels of training or issues get raised that might otherwise not. Could you give some examples of that?
Yeah, for sure. So what tends to happen, and this is anecdotal, I do not have research to support this, but I do these trainings quite often. So speaking anecdotally from personal experience, what I see happen is everyone responds together. And as Regina and some others have mentioned, sometimes there is interpersonal conflict between different types. He didn't mention that specifically, but within the agency, sure, but also within other types of responders. And so what happens when discussing the call types or the individual stressors, that moment when they start to see in one another, oh, that relates to you, or they start adding perspective, the conversation broadens. And this is much more broad than just law enforcement. We know that all first responders are affected by this. But as people start to explain the different perspectives, the conversation broadens and becomes much more rich. I think this is something, again, that probably should be researched in more depth. This is anecdotal, but that has been my personal experience. The conversation becomes much more rich.
Thank you for your response. And another question came through chat, and this question is addressed to Dr. Sital. I'm reading the question. I am a retired officer after 29 years. I know and have worked with many deputies. Currently, I am hearing the main issue with stress-related problems are the incredible amount of mandatory overtime, which is affecting every aspect of their life, and the fact they do not feel supported by the administration. Is anything being done?
So that is obviously a very important question. As it relates to mandatory overtime, the department executives are in the process of making some recommendations for changes. And because the ability to change some of the requirements involves multiple partners, they're in the process of really bringing in the folks that have a vested interest so that collaboratively they can make decisions. As it relates to overtime, I happen to believe that it is a huge issue and a huge stressor for our department right now. It becomes very difficult to say to an employee, your work-life balance is important, or being able to have a life outside of the demands of the job is important when you're working multiple overtime spots a month. It becomes very difficult for anyone, even somebody that would be healthy or balanced otherwise, to do that. And so as a department, we have to look at that. And I've been very vocal about that. And I believe that our department management now is really in a place where they're primed to make some significant changes. So that is being looked at. In terms of the disconnect between management and between our personnel and our employees that are working on the line or just involved in activity where they're providing service, I think that part of where we need to improve as a department is really for our supervisors, our line supervisors, to really have the support that they need to have some of these difficult conversations. Because our line supervisors and certainly peers are seeing folks every day, day in and day out. And so some of the indicators that may be potential warning signs that Joe was speaking about earlier, I think they are primed. They're in the best place to be able to recognize those things and then to be able to get support. And sometimes those conversations are very difficult in this population that we work with. You can work with somebody for a number of years and maybe not have the most open discussions about life outside of the job. And that's not uncommon. And so really our bureau, and then really part of our peer support cadre too, is really responsible for helping line supervisors and line managers have those conversations. And it could be just something as simple as providing a script or providing just an initial talking point. But employees are not going to talk about what's going on until they feel safe. And if they're feeling safe with the supervisors that are around them and the peers that are around them, then they may talk. But it is a huge deal for this population of individuals to take that initial step and get help. And whether it's help within an internal bureau like ours or whether it's external, that initial step and taking that step to get help, it is 100% a sign of courage. It takes a lot to be able to do that. So our bureau as well, we're looking to help facilitate that however we can.
Thank you, Dr. Sital. Another question came through chat from Lini, and this question is for Dr. Sital and Dr. Brown. Do your organization support MFT interns who are former law enforcement public safety officers from one of the various departments under the umbrella of Los Angeles County, current, former, or retired county employees? If so, where can we obtain more information on internships?
So I'll touch on that very quickly first. So in terms of our internal department and then the contractors that we also utilize to provide services externally, we have qualifications related to licensure as a psychologist. However, as I'm sure any of the panel members here that have had that exposure will tell you, it is extremely difficult to find qualified, competent providers that provide services for law enforcement personnel. And so having somebody with a background who has done the job, who's now going on and getting the certification as a mental health professional, we do informally refer to folks all over the county. And we do have a number of providers that are maybe not licensed at the level of psychologist, but licensed at the level of marriage and family therapist or clinical social worker. And we definitely will use them and certainly want to develop relationships with folks that have the experience needed. Because at the end of the day, especially for our population, really, our population doesn't care as much about your level of certification or your credentials. They care how you can help them and who you are as an individual. And so hey, that's my thought on that.
The answer to that, the Department of Mental Health does accept that. And really, we have a large number of licensed marriage family therapists on board to provide services. You can apply through our website, dmh.lacounty.gov, for the mental health clinician. If you're not licensed, you can apply for the mental health clinician 1. If you're licensed, mental health clinician 2. Now, I do have a question back to you because you mentioned internship. Are you looking for an internship to complete your degree or to complete your hours?
Before we get another chat from the person, so let me read the question from Commissioner Irma Garcia. I'm sorry, Irma Cooper. And the question is for Stephen Sital. Any data collection on the effectiveness of your program in its 50 years?
I apologize, I missed the first part of the question. If you could repeat, please.
Sure. Any data collection on the effectiveness of your program in its 50 years?
So we have done some internal studies, just gauging accessibility to services and internal department members' openness and receptivity to services. Unfortunately, with our department our size, statistical significance is a little bit challenging, and so we haven't been able to get anything that we would be able to share in a meaningful fashion. But certainly in terms of our services, that's something that we're continuing to look at. And we definitely invite feedback informally or anecdotally regarding our services.
Just wanted to add in on your comment, Dr. Sital. In research for this presentation, I did come across the Department of Justice Community-Oriented Policing Services, a report where titled Law Enforcement Mental Health and Wellness Programs, and the Psychological Services Bureau was noted as one of the case studies of departments across the nation, which I'm sure you were aware of. So I just wanted to put that out there because thought it was good information to see how what's being done here in the County of Los Angeles.
Thank you. Yes, I am aware of that the study, the case study, and so unfortunately, I think as it relates to just the department our size and then the ability to get feedback as it relates to our services, it's a little bit more challenging. And I think with case studies and the opportunity to present our services, we've been fortunate in that regard.
And I guess the attendee asked the question about the hours, the practicum hours. Dr. Brown, you were asking, they responded.
Yes, we do have trainings. We have our training division that really works very closely with all the schools to bring individuals to do their practicum and to complete their degree. So yes, we have the program available, and I can provide my email at the end, so then I can provide additional information.
And a question came from Commissioner Cooper. Again, Dr. Garcia, can you share the article?
Yes, I will share it and have it sent out.
A question came right now. It says, does DMH still require a non-licensed clinician to be licensed within 1 year of hire? I have all my hours needed. I just wanted to know how long I can work for DMH before I have to be licensed.
Actually, the department provides 6 years to be licensed, but it really goes in coordination with when did you first register with the Board of Behavioral Sciences and how much time you have. So if you are, a new graduate and just come from the beginning, you have 6 years to complete your hours. And generally, if you work full time, you can complete those hours within a couple of years, which give you 4 years to take your exam. If you have worked in the private sector, that it has to be taken into account when you register. What do you have, and what is it that you need? But we hire individuals without being licensed, and we provide the clinical supervision that is necessary. And we have a lot of openings if you would like to join the department.
And they added that they are working for another department.
Yeah, there are transfers, and if they're working for another department, you still have to apply through our website. If you are a licensed marriage and family therapist or marriage family therapist, you apply for mental health clinician 1. If you are a clinical social worker, you apply for psychiatric social worker 1.
Thank you, Ms. Brown. And they are requesting your email or contact information, Ms. Brown.
It's M Brown, BROWN, like the color, at dmh.lacounty.gov.
Thank you. No more questions.
Welcome.
question came right now. Does LASD encourage peer support or other preventive measures?
We do. We have a cadre of about 160 peer supporters that are trained, that are assigned to various units. And the model that we use is that they provide peer support within the unit that they're working in. And so they have contacts. They will have contacts if their position is flexible enough, they may be able to spend time and talk prior to shift or after, or get a few minutes in between. But we also have legislation and policy related to protections for peer supporters as well. So we continue to look for ways that we can increase and utilize our peer supporters in a way where the consumers or the department members that are engaged in those contacts feel comfortable and protected to share. Certainly, it's not the case with us, where in our bureau or in our department where everybody that is in need needs to come see a psychologist. There are several times where spending time with peer support is really meaningful and beneficial in ways that perhaps a mental health provider or somebody that is not connected on a deeper level, day-to-day level with the responsibilities associated with the job would know.
Another question just came in. What training and policies are being developed to address the stigma of mental health, asking for help, and a culture of toxic individualism within LE?
I can take a stab. I don't know the effort. I don't know all the efforts at place within law enforcement, but what I will say is that talking to law enforcement agencies, and we see this in the general population, as the younger cadre of as young adults have more open, are more willing to talk, have less stigmatized views towards mental health treatment in the American population, and so as they enter law enforcement, as that cohort enters law enforcement, we're seeing less stigma among younger law enforcement officers, more willing to talk about their mental health and more willing to access mental health services. There is a question though, because mental health is so stigmatized in law enforcement agencies, the question is whether that younger cohort will have the ability to change the culture in law enforcement agencies, or whether the culture in law enforcement agencies will suppress that openness that currently exists in the younger cohort. And I don't know what will happen, but I think that there is an opportunity for law enforcement agencies to capitalize on the beliefs and attitudes among their younger officers to really embrace and promote mental health to address the stigma.
Thank you for the response. And another question just came in. Please describe any type of data that the panelists maintain related to preventive services and if they are posted publicly.
So
So
I would say,
go ahead, John.
oh, go ahead. I'll take just a real quick one here. The National FOP is one place to start. They have a vetted wellness provider list, but since the majority of this is the sheriff's department, that I don't know how much of that applies locally there, but that is one vetted list that's available nationally. And they're, from what I understand, I don't know all the details of, but they're starting to collect data on the back end of that as well.
And I would just recommend going to the Suicide Prevention Resource Center website, sprc.org. That's a resource center that is supported by SAMHSA and the US government. And so they have a library of suicide prevention resources available. They're not necessarily specific to law enforcement, but I think that they have efforts specific. They have some things that could be applied. The other resource I'd recommend is the National Action Alliance for Suicide Prevention website. They do have something. I don't know if they have something specific to law enforcement, but they definitely have something for workplaces. So strategies workplaces can use to prevent suicide, and law enforcement is unique. I'm not trying to diminish that, but it's also an employer. And so there could be lessons gleaned from those resources as well.
Thank you. Another question. Does the Sheriff's Department offer mental health positions to MSW and MFT clinicians? I often see positions for psychologists. This can be very limited.
Yeah, so unfortunately, in terms of the mental health professionals that we currently extend positions to, it is only psychologists. And I say unfortunately just because previously we had talked about just the value of some other disciplines as well. But there are benefits to having psychologists just in terms of the services that are provided. What I would say is that if somebody is a provider who's licensed in the Los Angeles area, if they have experience working with law enforcement, then certainly we would want to hear from them and talk a little bit about their practice and see if they were a viable referral resource.
Thank you. And Commissioner Garcia, we don't have any other question.
Thank you, Nune. I just have one final closing question, and I think it centers around, I'll direct it towards Mr. Willis. You know, in your work in your organization, you know, I think on a larger kind of national scale, you know, community perceptions of law enforcement and how that impacts mental health, you know, critical incidents and exposure to violent, you know, just, you know, the work that law enforcement does, and you know, is witness to, so, you know, these tragic incidents that, you know, the general public doesn't necessarily will be exposed to. Here in the county of Los Angeles as well, you know, we have critical incidents, and it from your presentation, you know, it spoke to this kind of like early intervention, prevention, and kind of wellness campaigns is what I was gleaning from it. And I just want to kind of get your thoughts on you know, kind of bringing more awareness to kind of the early intervention prevention services on wellness, and you know, being able to check in with the peer. I know we do it for you know, community members, you know, and the like, but for, you know, with, I think it'd be important kind of stigma breaker if that more of that kind of information was brought forth to law enforcement personnel, and kind of break those stigmas of seeking help, or just even asking, you know, just, hey, I'm dealing with some stuff, you know, can I talk to somebody? I need, you know, pick up like peer.
Yeah. So I think this would also, if Dr. Sital or Ms. Brown wanted to jump in, because they both kind of actually, I think all three of the presenters alluded to this. I think a few things need to be done, because yes, thwarted belonging is a precursor, and oftentimes when law enforcement experiences that constant bombardment of national scrutiny and local scrutiny, and getting that constant exposure to that does play a part in it. And as Rajiv mentioned, the internal toxicity, even one of the questions kind of alluded to it. When we're experiencing both of those at the same time, man, it gets hard, really hard to feel like I belong here. And we're seeing an exodus. I don't know how LASD is experiencing this, but we're seeing an exodus across the country to jobs like UPS, right? Because people love their UPS driver. So what we're finding is that the more we can do to promote left of the problem, as far left as possible, go to the academy and remind people that as a general rule, people trust law enforcement. Studies done historically by Gallup indicate that law enforcement remains one of the most trusted professions in America, above clergy in many cases. That historically, even at our lowest points, remains there. I think sharing that message is one of the things. And then the second thing I would add to that is I mentioned that range of resilience, and why I picked that tool specifically of all of the ones we have in our inventory is I think many of us on this call are the kind of people when we walk into a room and we start talking to frontline people, they're like, oh, there's the wellness guy. There's the one who is going to talk to us about this thing, right? I like our range program because what it is it's a chain linkage all the way down to that person teaching the front line. I want my firearms instructors. I want range cadre, those I almost said the crusty old range masters, but if you're a range master at LASO, there's a chance you know this person. I want that person talking about mindfulness. When that person who's been rolling around on the mat with you during DT training, or the woman who just tased you for your taser exposure is talking to you about recognizing the good and joy and gratitude, you're going to listen to that person. And so I think, but not I think, I know, I mean, research supports this. We're very evidence informed on this because there's a lot more outside of law enforcement than there is within it. But what we find is the more we can get down to that ground level and expose them to resilience skills as early as possible, and it's supported by that triad with leadership support, that's where we see the impact. I hope that answered your question, sir.
Yes, it does. Thank you very much. Okay, well, thank you, everyone. This concludes this part of our presentation today. At this time, we would like to take a moment of silence to show respect for people we have lost due to suicide. Thank you. Law enforcement mental health is an issue that requires further discussion. I would like to bring this topic in front of the full Civilian Oversight Commission for further discussion and review at a future meeting. Psychological health and well-being of Sheriff's Department personnel is fundamental to the safety of our communities. We appreciate the panelists' expertise here today, and as community members, I urge you to provide written public comments with your thoughts about law enforcement mental health. A link has been placed in the chat, and you can always visit coc.lacounty.gov to provide the commission with your thoughts and concerns. Your comment can be submitted anonymously, and we take your feedback into consideration when prioritizing our work. Thank you again to each of our panelists for sharing your thoughts, to the community members for tuning into this important conversation hosted by the Civilian Oversight Commission. The next commission will be held Thursday, December 14th at 9 a.m. at Pet Park in San Pedro. And we hope you can join us in person. Please visit coc.lacounty.gov to follow for information. Thank you, everyone, and have a wonderful day. This concludes our conference.